Thank you very much for joining this exciting symposium sponsored by MEDTRONIC on clinical path for CRRT in neonatal ICU and adoption of different modalities, technologies, and barriers to these technologies. We have two exceptional speakers today, Professor Stu Goldstein, an old friend and an excellent scientist from the Cincinnati Children's Hospital in USA, and Professor Enrico Vidal from the University of Udine in Italy. It's a fantastic topic that, as you know, I'm not a pediatrician, but I love this topic, and I'm really curious to see what the experts will present us in this important symposium. As you know, when we planned the Vicenza meeting in person, we had one entire day devoted to pediatric CRRT and AKI. Unfortunately, we had to reconsider the program, but hopefully we will have the full program next year in Vicenza in person. So with no further ado, I would like to ask Professor Stu Goldstein to share his screen and start his presentation for this symposium. Stu?
Thank you very much, Claudio, and I appreciate everything you and the folks in Italy and Vicenza have done for children who require CRRT. And it's especially an honor to share the podium with, well, I guess the virtual podium with Dr. Vidal. So my disclosures are that I consult for and serve on the speakers panel for MEDTRONIC, Baxter, and CHF Solutions, all of which market CRRT devices in the United States, and I will be discussing these devices. So we know from the KDIGO paradigm that we have to think about when kidney replacement therapy should start and when it's really kidney supportive therapy. And what's really been remarkable over the last now 8 years since the KDIGO AKI guidelines were published was that everything that we considered for adults and for older children is actually true for neonates. Neonates were a forgotten group or an understudied group of children who developed acute kidney injury requiring kidney supportive therapy. And we did not have technologies that were specific for them. And this has changed again over the last decade. So we have a number of options: hemodialysis, peritoneal dialysis, and CRRT. Each has advantages and disadvantages that are guided by patient characteristics, disease symptoms, and hemodynamic stability, and also by the goal of the therapy. Is it fluid removal, is it toxin removal, or prevention of fluid overload? And the availability, expertise, and cost of a specific therapy is really important. And again, in the neonatal intensive care unit or in the cardiac intensive care unit with neonates, having the expertise and the need for expertise is magnified with very small children and extracorporeal therapy. So up until recently, we've had a number of tools that really have not been directed specifically for this population. Just to go through these in a little detail, intermittent hemodialysis is, of course, an acceptable therapy. We know about, have been using this for decades now, and it's a high efficiency system, and fluid is removed by ultrafiltration through a transmembrane pressure across the hemodialysis membrane. CRRT, or kidney, or CKRT as we're calling it now, is very similar to hemodialysis, except it runs continuously and the particle can be removed by convection or a combination of diffusion and convection. And the clearance rate is approximated by the total effluent rate. On a minute-to-minute, hour-to-hour basis, it's less efficient than hemodialysis, But Dr. Ronco has shown that over a day you can get superior clearance with CRRT. And peritoneal dialysis is the most commonly used renal replacement therapy modality in children. Sterile dialysate is introduced into the peritoneal cavity through a catheter. The particles are removed only by diffusion, and the fluid removal is by ultrafiltration again, but using an osmotic gradient that employs dextrose. So the advantages of hemodialysis is that it is the most efficient dialytic clearance. There's relatively accurate ultrafiltration. It is an intermittent procedure, so the patient can have other procedures done while not on dialysis. However, ultrafiltration may not be accurate enough for neonates and infants. All hemodialysis machines have some obligate ultrafiltration, which can be significant based on the size of a neonate, and the ultrafiltration is volumetric and not gravimetric. There's a relatively large extracorporeal volume to patient volume. Regional circuit anticoagulation is not the standard practice, so these neonates would be exposed to systemic heparin. Vascular access is required, and low blood pump flow rates are not available, which are important for small infants. Peritoneal dialysis has a number of advantages. Less technical expertise and resources are needed, so peritoneal dialysis can be performed easily in resource-strapped countries and environments. There's no need for vascular access, no need for anticoagulation, and there's actually no need for ICU care in many instances. There are, though, in the acute situation, a number of disadvantages. Fluid balance and clearance are not able to be prescribed precisely. It requires adequate perfusion pressure to the peritoneum to be effective. The risk of peritonitis is real, and catheter malfunction is not infrequent and requires often another trip to the operating room or catheter rest until the catheter functions normally. And abdominal surgeries can preclude the use of peritoneal dialysis in many instances. Continuous kidney replacement therapy, accurate ultrafiltration is easily achieved. Most platforms use gravimetric control. Newer platforms are able to achieve low blood pump flow rates accurately. Regional citrate anticoagulation is the standard practice in pediatric CRT. A continuous procedure allows for calibration of therapy throughout the day. Convection, diffusion, and a combination are available. The disadvantages, again, vascular access is required. Some circuits will have a relatively large extracorporeal to patient blood volume, and it requires significant interdisciplinary collaboration between dialysis programs, ICU programs, and communication between a number of healthcare individuals. So when should we start kidney replacement therapy? Well, that is the million-dollar question. We don't want the risk to outweigh the benefit, and it used to be thought to be way too risky to do anything but peritoneal dialysis in small children. However, work from the Prospective Pediatric CRRT Registry Group, a consortium of 13 U.S. centers which enrolled patients into a prospective observational registry, looked at, from 2001 to 2005, looked at small children, and this work by David Ashkenazi showed that even in the early part of the 2000s, survival rates that were achieved were greater than 40%. Now, these weren't as high as for children who were greater than 10 kilos, but still, this is not a futile therapy. And what Dr. Ashkenazi and the group showed again was that fluid overload at the start of CRRT initiation was higher in those patients who died compared to those patients who survived, suggesting that we should be starting earlier in smaller children, just as we've shown in older children and adults. So I think it's important that we must acknowledge that it is amazing that we do continuous kidney replacement therapy in babies, but even with the best practices, this approach exposes the smallest children to added risk. So we, again, have to think about the risk-benefit ratio, but the risk of doing nothing is 100% mortality. So when do we think about timing kidney supportive therapy? What type do we use? How do we prime a circuit? And up until recently, the current technology was not designed for neonates. And we often are doing very high affluent volume rates for patient size. So we have to think about the things that we're removing that we don't want to remove, including drugs, including amino acids. And this is a very specific type of cohort that we need to pay attention to. So what's advanced in the last 20 years since the PPCRT? Well, let's use a newer filter, and I say it's newer in quotes here because it's been available in Europe for many years. The HF20 filter for the PrismaFlex and PrisMax device has a 0.2 meters squared surface area, far smaller than any other filter available on standard CRT platforms. It has been available in Europe for over a decade, and now it is available in the United States under an FDA emergency use authorization, and the target patient weight is 8 to 20 kilos. On the right-hand side, you see a prospective study that we ran in the United States in order to achieve FDA registration for the HF20 this past year, and you can see there's excellent blood urea nitrogen removal at 24 hours. Let's use a new machine. And we have that new machine, but that is going to be the topic for my good friend, Dr. Vidal. The NIDUS system is essentially a single needle hemodialysis system in Newcastle in the UK that is miniaturized for infant infants. And this publication is now about 8 years old, but you can see the type of patients who've been treated, very sick patients, some with end-stage kidney disease, others with inborn errors of metabolism. And you can see the number of hours here. And what was demonstrated is that there is good urea, creatinine, and phosphate clearance, although this technology is not widely available. Let's adapt a machine. So in the United States, David Ashkenazi again adapted the CHF Solutions Aquadex device by taking advantage of the fact that it is a small filter size of 33 milliliters, and created a situation in which pre-filter hemodilution, pre-filter CVVH was done. And in this initial study, you can see excellent creatinine, blood urea nitrogen, and sodium control. We applied the Ashkenazi method to our neonatal intensive care unit, where for many years children with who were diagnosed prenatally with congenital anomalies of the kidney and urinary tract would receive peritoneal dialysis if they had end-stage kidney disease after birth. We noted 2 abdominal catastrophes in patients in 2014, and I believe it was because these patients were in a catabolic state and their gut integrity was not normal, since they had no kidney function at birth. So we tried the Ashkenazi method in 2014 for patients, providing daily modified CVVH for 6 to 8 hours a day for 2 weeks, allowing the peritoneal dialysis catheter to heal. 21 patients, now 22 patients have been provided with this form of modified aquapheresis, and our survival to discharge from the hospital on maintenance peritoneal dialysis is now approximating 50%. We are seeing some associations with the type of bladder outlet obstruction or congenital anomaly of the kidney and urinary tract with survival. You can read more about this method in a paper that was published by Dr. Shaina Menon, Dr. Ashkenazi, and myself, looking at how to employ this technology in a CVVH mode off-label in the United States to get some ideas if this may be relevant to your practice. So now it is time for my cappuccino and to hand it over to my good friend, Professor Enrico Vidal. Thank you so much.
Well, thank you very much for the cappuccino image. I remind you that many years ago, we did a fantastic cappuccino in a villa in Vicenza when the Carpe Diem machine just came out, and we had the pleasure to discuss this. It's interesting, just a burning question that you did not mention the whole large experience we had with continuous arteriovenous hemofiltration in neonates. Is this because you consider this as an obsolete therapy, or just because you think it was not sufficiently adequate? What was your view about this?
Yeah, I think that the experience with CAVH and the landmark paper of yours in Kidney International that demonstrated that CAVH could be done was really a turning point for pediatric acute kidney injury support. However, I would say that since the mid-1990s, with machines that have gravimetric control and the ability to really prescribe ultrafiltration more accurately, especially for smaller kids, Claudio, trying to match ultrafiltration and replacement based on what the heart can drive through transmembrane pressure, really is so challenging that I think the machines have been adequate to supplant CAVH as a viable therapy currently.
Yeah, let's not forget that this was the same evolution we had in adult patients, of course. The only thing is that there is a lag phase, a little delay of the transition from adult to pediatric technology. So everything occurs a little bit later, let's say. So with this, I welcome Professor Vidal, and I will ask him to share his screen for the presentation.
Okay, so are you able to see my screen now?
We are.
Okay, so thank you very much, Professor Ronco. Thank you very much, all the organizers, for having invited me in this beautiful symposium today. So, Professor Goldstein has clearly underlined what are the barriers to the application of an extracorporeal renal replacement therapy in neonates. And these include problems with the vascular access. It's quite difficult to find an adequate balance between the recommended size of the access, the small size of our patients, and the need of achieving an adequate blood flow. We have problems with the blood volume, and this is because you know that the priming volumes of most of the adult machines that we use for treating neonates and infants are quite large. And so this is associated with a risk of having hypotension, of having a huge high immediate dilution of the baby's blood. And it's also associated with the risk of having sensitization because of the need of having a blood prime, and so the need of having repeated transfusions. And the third problem, in my opinion, is that the accuracy of the ultrafiltration volume is not so accurate when dealing with neonates and small infants. So let's focus now just in the first point. And we know from the Poiseuille law that the flow inside of a catheter or inside of a tubing system depends on the pressure and depends on the fourth power of the radius, and it's inversely associated with the length of our tubing. So if our aim is to increase the flow inside of a catheter or inside of an extracorporeal line, what we should do is to increase the radius. And this is exactly what has been demonstrated by the prospective pediatric CRRT registry. This is a quite famous study Here we have the proportion of the survival of the catheters over time. And as you can see, we have two groups of catheters. This is these big groups of catheters ranging from 7 to 12 French. And the survival of these catheters is clearly superior than that of a 5 French catheter. So the main message from this slide is that when you are treating a neonate or a small infant with an adult machine, please do not use. So we said that it's not quite easy, you know, to place a big catheter in a small neck such as this baby. This is a 6-point French catheter. It's quite large. And the risk associated with this catheter is a risk of having infections, but above all, a risk of having thrombosis. So this is quite an important problem. So the second thing that we can do if we want to increase the flow is to try to increase the pressure, okay? But again, this may result in a problem when dealing with small children. This is a typical blood pump, a pump that we have in our adult machines, in our units. And you know that the blood is moved by the action of these two rotors that push the blood in this extracorporeal line. And when we couple this type of pump with this small catheter, this is the risk of having a pressure profile. So the risk is of having high venous pressure, low arterial pressure. This prevents the continuation of our renal replacement therapy, results in several alarms, and is associated with a risk of having clotting in our extracorporeal circuit. So how can we solve this problem? The first thing is to try to not use blood pumps to move the blood when treating neonates or infants. And this is exactly what has been done, for example, by the NICU system. The NICU system is a system in which the blood is moved using syringe, not using pumps. And the second thing is to try to develop new type of dialysis pumps. So to move from one type of pump that's characterized by having these two big rotors to a new type of pump where we have increased the number of rotors, reduced its size, and reduced the overall dimension of our pump. So from a practical point of view, this is the result. So this is the typical movement of an adult pump, in which, you know, the pressure that these rotors give to the line is quite high. And this is the new type of pump that it's incorporated in the CRRT NICU machine. As you can see, tend to move faster, but the movement is more gentle. It's like a kind of cradle movement to the extracorporeal line. So this type of pump is associated with this type of pressure profile, and this type of pump is associated with this type of pressure profile. So this machine cuts the pressure, and this allows us to work with smaller catheters. We've also tried to analyze this using an in vitro system. Here we have coupled an adult or a pediatric pump together with a flowmeter that was placed both in a post-pump or in a pre-pump configuration to calculate the inflow pressure profile or the outflow pressure profile. And as you can see from this graph, in media, the use of the CRRT NICU pump tend to cut the pressure of at least 20 millimeters of mercury. The other thing we did was just to analyze the use of an adult pump and the use of a pediatric pump together with 3 types of catheters: a 4 French 6 centimeter catheter, a 7 French 15 centimeter catheter, and a 5 French 5 centimeter catheter. And we have defined a safe range of pressures, a range between plus and minus 100 millimeters of mercury. So the upper part of this threshold was reached at 10 ml per minute with a 4 French catheter using the adult pump, a 13 ml with the 7 French catheter, and a 20 ml per minute using the 5 French catheter. And all these values were consistently increased using the pediatric blood pump. So according to our study, to our in vitro study, but also according to our experience, in our opinion, this is the best catheter, the best compromise when treating small infants using the Carpe Diem, so the 5 French 5 centimeter catheter. These are data from our retrospective registry. These are data from 23 patients treated just with a convective modality. As you can see from this table, most of patients were treated with a 4 French or a 5 French catheter, reaching median blood flow between 10 to 30 ml per minute. But if you focus on the left part of this table, you can see that in 3 cases, we were able to use a dual lumen 3 French catheter. And also in 3 cases, we were able to use 2 umbilical catheters, one 5 French and the other 3.5 French catheter with quite good median blood flow. So the other 2 barriers we have with the application of extracorporeal renal replacement therapy in neonates are those related to the blood volume and to the inaccuracy of the fluid removal. In this table, I've just summarized the technical characteristic of the most important monitors we have in our unit. These are adult monitors. And if you look here at the priming volumes, the priming volume with this monitor and using pediatric setting is something in the range between 60 to 80 ml. And we know that the priming is safe when treating neonates and infants when the extracorporeal volume, that's the summation of the volume in the lines with those from the filter, when this is lower than the 10% of the baby blood volume. So in an example, for example, if we are treating an infant weighing 4 kilograms with an overall blood volume of 320 ml, the priming should be less than 32 ml. If not, we need to prime the lines with blood, and again, we can increase the risk of having sensitization. The other point from this table is the accuracy. And in most of these machines, the accuracy is set at plus minus 10% of the ultrafiltration setting. This, in example, if we are prescribing an ultrafiltration of 1000 ml over 24 hours, this eventually may result in achieving 900 or 1100 ml over 24 hours. That's not a small difference when treating very small infants. So all these problems have been tackled by the Carpe Diem. That's a machine specifically conceived to treat babies weighing less than 10 kilo. We can prescribe CVVH in both pre or post dilution, or we can prescribe CVVHD. We have 3 configurations available with filters of different surface areas ranging from 0.075 to 0.25 square meters, and an extracorporeal priming volume that is quite low, between 27 to 41 ml. We have a maximum weight loss programmable of 1 kilo, and we have a significant weight loss accuracy that is set at plus minus 30 grams in 24 hours. And the control of the ultrafiltration in the Carpe Diem, it's quite complicated, it's quite complex. It's based on a dynamic system, and these data have been demonstrated using both in vitro and in vivo testing. So I would like to present now some clinical data from our registry, the Carpe Diem registry. That's a registry set in Italy. We have started enrollment from June 2013, and we have published our experience with the convective modalities, but also with the CVVHD. Quite recently, we have published our experience of treating 26 patients with the CVVH. As you can see from this table, the age at ICU admission, the median age at ICU admission was 1 day. The median age at CRRT initiation was 8 days. The median body weight, 2.9 kilos. in the vast majority of cases, the primary diagnosis was a cardiac disease, and the indication for CRRT was fluid overload and or electrolyte imbalancing in most of patients. We tend to use more pre-CVVH. If you look at the prime, in more than half of cases, the prime required was just normal saline. Blood was required just in 11% of cases. With this machine, anticoagulation can be possible using only heparin, so there is not the possibility to perform anticoagulation using citrate. But as you can see, heparin, in our experience, was used in, let's say, almost 2/3 of cases, and 28% of patients were treated without using anticoagulation. The median blood flow was 4.5 ml per kilo per minute, in a median dialysis dose of 37 ml per kilo per hour. If we look at complications, we have a quite good over-delivered ratio, 81%, and the most important causes of downtime result in clotting in 30% of cases, clinical reasons in 7% of cases, and vascular access malfunction in 6% of cases. What about the outcomes? The survival at CRRT discontinuation was 96%. The survival at ICU discharge was 50% of cases. We've also calculated in our population the determinants of mortality, and this resulted to be the lower gestational age, the lower body weight, the higher PRINCE score at ICU admission, and let's say the longer stay in ICU prior to start the continuous renal replacement therapy. For the CVVH-HD, from November 2016 up to May 2018, we were able to treat 13 patients. These are the characteristics, the clinical details of our 13 infants. As you can see, we were able to treat 4 patients because of an end-stage renal disease, 6 patients because of AKI with or without fluid overload, and 3 patients because of hyperammonemia. And in this slide, I have summarized the trend of ammonia levels in the 3 patients treated because of hyperammonemia. We may define, let's say, safe threshold or ammonia, a threshold below 500 micromoles per liter, and this value was reached in all 3 patients within 12 hours after the start of the CVVH-HD. In this slide, I have summarized, in my opinion, an important factor. This is the trend in the whole cohort of patients of the venous pressure and the arterial pressures from the start to the end of the session of the CRRT. And as you can see, the variation from the start to the end session for both pressure is quite low. And also the variation is within the safe range of plus and minus 100 millimeters of mercury. What about the outcomes? This is a study quite recently performed by Stu Goldstein. Stu put together all our data from the retrospective registry, so overall case series of 38 patients, and he compared this patient, compared the outcomes of these patients with those from the prospective pediatric CRRT registry. And if we look at the survival at the end of CRRT, and when adjusting the survival for several covariates, what Stu found was a consistent higher survival in the Carpe Diem as compared with the PPCRRT registry for whole subjects, and also performing sensitivity analysis, including those subjects with AKI only, those subjects receiving mechanical ventilations, and those subjects receiving vasoactive medications. So the conclusions: recent technology developments have transformed infant and neonatal hemo from an orphan disease to ectopic. Now we have dedicated equipments that might facilitate the application of extracorporeal blood purification in small patients. So Now, in this specific age group, the CRRT is not only a rescue therapy for neonates and small infants who have severe fluid overload and or APD failure, but should be considered an elective therapy in case of AKI, maybe in case of hyperammonemia, and in those neonates with end-stage renal disease who show hypercatabolic complications. These, in my opinion, are the most important characteristic of the CRRT dialysis system. We have now a newly conceived small free-roller blood pump. We have the possibility of achieving high clearances with adequate central venous lines, adequate for the small size of our babies. We have the possibility of using small extracorporeal volumes, and we have a dynamic fluid balance control with a very low error resolution that is quite safe. The CRRT is also a promising field. I think that one of the most promising field will be the use of plasma exchange for treating several conditions in neonates and the infants. And the other thing, in my opinion, is that we should consider the CRRT not only as a platform for giving a renal replacement therapy to our small patient, but should be considered like a potential platform for giving extracorporeal renal support to this specific population. So let me just conclude to say a big thank you to Professor Claudio Ronco and also to the technical staff of the International Renal Research Institute in Vicenza. Thank you also to you, Stu. Please remember that in Italy, the time for having a good cappuccino is just in the early morning, and now it's Prosecco o'clock. Thank you very much.
Thank you very much, Enrico. And I have a little surprise for both of you, because I just found the original drawing that I made for the Carpe Diem. And if you like, I can somehow make a print from this and send it to you in a frame just as a memory.
Thank you very much.
Great, and please sign it, Claudio.
Okay, I will be pleased. So the idea is that we finally are moving from a artisanal or adoptive technology to a technology specifically designed for babies. I think the important issue was, when I designed Carpe Diem, I didn't want to patent this because I wanted the machine to be open and possibly improved by everyone. I think that it should be like this for neonates that require specific attention. How do you see the future of this machine in the United States, Stu?
Yes, so Claudio and Enrico, we have FDA approval in the United States since April, and we are being very deliberate as we disseminate the technology. There were a lot of missteps early on with pediatric CRRT back in the mid-90s and early 2000s, and you could go to many children's hospitals and people, a number of high-profile hospitals would say that this was a futile therapy. And what neonatologists are not familiar with CRRT, so we want to be very careful as we disseminate this. And technology will speak for itself, but we need to train folks appropriately. And the machine is very different in the way that it is programmed and prescribed than other technologies. However, Claudio, I can tell you, since the publication of the first patient, who is the subject of your book and of the Lancet article, not 2 weeks, and that was in 2014, not 2 weeks went by without somebody in the United States saying, when is the Carpe Diem going to be available? So I think this is going to expand support for children who otherwise may not have been able to receive support. I think the indications will be large and broad, a number of centers are very interested to see if the Carpe Diem will work with ECMO, and we have actually proven that it'll work with ECMO in our simulation lab. So I think that not only, as Enrico says, not only is this platform going to be useful for standard CRRT, but there are a whole host of other indications. And so you've built it and you've tested, and now I think they will come to care for kids in the NICU.
So it's interesting, you made 2 points. One is the use with ECMO. You might know that in 1984, with Robert Bartlett, we did ECMO joined with arteriovenous hemofiltration with the mini filters in Ann Arbor, Michigan first, and in Mount Sinai subsequently. The other thing is, you are right, we need to train correctly the people, because I was involved in an evaluation of several complaints for one machine, nameless machine for CRRT. And when we evaluated the papers, 95% of the complaints were wrong, and they were due to misuse of the machine rather than misfunction of the machine. So this is extremely important. Enrico, your last question, are you going ahead with our registry?
Yeah, we should go ahead using a prospective registry now, because the data we have are just from a retrospective registry. And I think that we should have now more precise information, because the limit of using a retrospective registry, it's a bias related to the retrospective nature of our data. For example, if you look at our CVVH case series, one important factor associated with mortality was the late application, the late use of the machine in the intensive care unit. And this is, in my opinion, this was associated with a lack of confidence with the use of the machine by most of the pediatric nephrologists and also by most of the neonatologists. So maybe with a prospective observation and with a more frequent use of this machine, I think that we should try to remove this bias from the analysis.
Yeah, the more you do it, the more you love it. I think there is another issue, and the availability of CVVH-D instead of CVVH will help reducing the number of complications linked to misuse of bronch prescription of ultrafiltration versus blood flow and so on. Because at this point, it will be definitely easier to use diffusion in the system. So this is another opportunity. With this, I must close this wonderful session. We can go on forever, but we need to stay on the time. We thank Belco MEDTRONIC for sponsoring this symposium. And let's go back to the International Vicenza course on AKI and CRRT. Thank you to our speakers, and have a wonderful day.